All right, we are continuing our lectures on blood, and in this video, we're going to talk about leukocytes and platelets. So we'll look a little bit about their general characteristics and some of the things that could potentially go wrong with them. But again, we're not going to get into too much detail about leukocytes right now. We'll cover them in a little bit more detail when we do the immune system chapter. All right, so leukocytes are another part of the formed elements of the blood, but unlike the erythrocytes or red blood cells, these are actually going to make up a significantly smaller proportion. Again, we saw that buffy coat, which is made up of the leukocytes and platelets. So not a lot of these. They also tend to have a much, much shorter lifespan than the erythrocytes. Sometimes these cells can have a lifespan of just a few hours or even few minutes if there's a really bad infection going on. A lot of these cells will, in the case of an infection, actually sacrifice themselves. So they will gobble up a pathogen, a virus or a bacteria or whatever, and then actually degrade themselves or be degraded by another white blood cell in order to actually destroy that pathogen and prevent it from replicating and getting into any other cells. All right, so like I said earlier, the leukocytes are not necessarily going to exclusively stay in the bloodstream, in the blood vessels. That's just kind of like them using a highway basically, or a freeway. Once they've reached their target destination, they are going to leave the blood vessels and then migrate into the tissues. This is called emigration, shown right here. So they start out in those vessels, get to wherever in the body they need to be, and then they are going to emigrate or squeeze in between the cells in the wall of the blood vessels out into the tissue to perform their actual function. Some of them will stay in the vessels to go to other sites or to actually combat pathogens in the bloodstream directly. It's ideal to not have that happen, but it does in some cases. But usually infections are going to be found out in the tissues. Diapedesis is another term for this. So they are actually going to kind of walk or crawl themselves, squeezing out between those cells of the blood vessel. So we'll see that again when we cover the immune system later on in the semester. So once these get out of the capillaries, some of them actually go find the lymphatic tissue, so the lymph nodes, and set up shop there and kind of act as a surveillance system of things coming through the lymphatic system. Some of them will actually go back into the bone marrow, some will end up in the spleen, among other organs. So we've seen in a couple different tissues where we do have immune cells that are permanently part of that tissue type. And so that is where these are coming from. Some of these types of cells will actually change names depending on whether they're in the vessel or out in the tissue. So there are monocytes become macrophages once they leave the blood vessels and stuff like that. So the names can change a little bit, but we'll get into more details in another chapter. So in a clinical setting, in a medical setting, the percentage of these different types of cells in the bloodstream can indicate different types of infections or disorders or diseases present in that person. We'll talk about that a little bit later in this video, but one of the things that triggers this diapedesis or emigration is something called chemotaxis. And so what we're seeing here in these images is we've got this cut and it's been infected with a pathogen, most likely a bacteria in this case. And so we see these bacterial cells and they are going to release certain chemical signals, and then there's also cells in the surrounding tissues here that are also going to release signals saying, hey, we're injured, we're infected, we need help, and those chemicals will get into the bloodstream, and then that is how we give some of these white blood cells directions to the site of infection or injury, depending on the exact case. So they don't just have this magical way of knowing where to go, they are getting these chemical signals to give them directions on where they need to end up. All right, so let's talk briefly about these different types of leukocytes or white blood cells. There's two main groups, granular leukocytes or granulocytes, which are shown over here. And then there are agranular or agranulocytes. These are going to not have these big chunks of granules that you see. So we've got three types of granulocytes: eosinophils, basophils, and neutrophils. And then we have two main types of agranulocytes, which are monocytes and lymphocytes. And so you can see the monocytes and lymphocytes don't have all of these dark little blobs inside of them. And so those are the granules that we are seeing. We'll talk about what those granules do in just a little bit. So these granular leukocytes, again, eosinophils, basophils, and neutrophils, each of them have a slightly different job within the immune system. And so the first one we're going to talk about are going to be these neutrophils. These are one of the most common type of white blood cells in the body. Neutrophils are going to make up between 50 and 70% of the overall white blood cell count. These are going to be pretty large, and they are, again, going to have these big granules. And one really big distinguishing feature of these is what we call a multi-lobed nucleus. So you can see this kind of dark purplish pink structure down in here, and then there's these little strings attaching them. So this is all the nucleus of these cells, and it just kind of separates out into these different lobes or chunks that are connected by tiny little pieces that keep everything attached to each other, but there are still going to have these broken up nuclei. So it can have anywhere between 2 and 5 or 6 little lobes. Usually the number will increase as the cell gets older, and so these can also sometimes be called polymorphonuclear cells, or PMNs. So that's a common abbreviation that you might see in a clinical setting as well. And so these are one of the first responders to sites of infections. These are going to be phagocytes, so they are going to gobble up different pathogens. They have a big preference for bacteria. They like to gobble up bacteria. And then these granules inside of them contain a bunch of enzymes and neutralizing agents, like hydrogen peroxide and stuff, that are going to actually start breaking down the wall of bacterial cells or fungal cells, and start destroying that particular pathogen once the cell has eaten it up and brought it inside of its cell membrane. Really high numbers of neutrophils can indicate really severe acute infections or inflammation. Usually, again, triggered by bacteria, but these can also be found in burn patients and other people with unusually high levels of physical stressors going on in their body. So being really, really sick can increase the number. And so one of the reasons that these are common in burn patients is burns make us very, very susceptible to infections. And so having higher numbers can help fight off those infections. Next up, we'll talk about eosinophils. These are only going to comprise about 2 to 4% of the overall white blood cell count. They're going to be similar size to the neutrophils, but far, far less in number. These are also going to have granules, and we can also see a bilobed nucleus here. So it will be in lobes, but there's only going to be 2 to 3, and so they're not going to have as many lobes as a neutrophil. One big distinguishing feature between the two, if you're looking at it under a microscope, is that they're going to stain slightly different colors. So these eosinophils are usually going to have the granules turn more of a reddish orange color, whereas the neutrophils are going to have the granules be more of a purplish or bluish color to them. So that's a really key distinguishing feature when you're looking at a stained blood smear between those two, because the nucleus, again, is not necessarily going to be a single defining feature. These granules in eosinophils have a lot of antihistamine molecules, which are going to counteract the histamines that we produce as part of our inflammation process. So these are going to be very, very toxic to parasitic worms. So really the main time that we would see high levels of eosinophils is if there was a parasitic worm infection happening in the body. So these can come in a couple different ways, but usually from raw or undercooked fish or meats. We'll talk more about that with the immune system. These are also capable of phagocytosis and are really good at disposing of things that antibodies have attached to, those immunoglobulins that can signal that something needs to be destroyed. Higher numbers with parasitic worms, but they can also help to a certain extent with bacteria and viruses as well. And then basophils are our next one. These are the least common type of white blood cell, usually making up less than 1% of the overall count. And so these are going to be slightly smaller than the eosinophils and neutrophils, not dramatically though. These are going to have granules that stain usually a very dark blue coloration, and they're usually going to be very, very large. So neutrophil granules can also stain a bluish color, but they are going to be much smaller than the granules found in the basophils. So these basophils have a slightly different job. They are usually going to help increase the inflammation response, and that inflammation can be due to injury and or infection, among other things. So they are going to help increase that response to help signal more white blood cells to come to that site of injury or infection. So higher numbers of these can often be associated with really, really severe allergies. So if somebody's in anaphylactic shock, they could have a high number of basophils. They can also be in high numbers with certain types of parasitic infections, and interestingly, hypothyroidism of all things. And that has to do with some of the inflammatory response. Lower counts are going to be associated with pregnancy and stress responses, really, really severe, intense stress responses, and hyperthyroidism, again, because of that inflammatory response. Moving over here to the agranular leukocytes, so they're not going to have those really giant visible granules. They will still have some, but they're going to be really, really tiny. We're not going to see them on a stain. And so we have two major classes, again, monocytes and lymphocytes. Lymphocytes are really important. These come from lymphoid stem cells, starting out in the red bone marrow again, but then finish out their development and reproduce in the lymphatic tissue, so lymph nodes primarily. These are the second most common type of white blood cell, about 20 to 30% after the neutrophils. They are a vital part of our overall immune response. These are the ones that are going to have very specific responses to a specific pathogen. So these are the ones that are remembering what an influenza virus looks like, what a E. coli bacteria looks like. These are the ones that are having that memory and really, really specific directed responses to different pathogens. The size of these can be really variable, so they can be really big or a little bit smaller. They are going to have very, very large nuclei, not a ton of cytoplasm, and so these are going to be classified into B lymphocytes and T lymphocytes. Each of those have slightly different jobs within the immune system, but they're both very, very important to our immune response. We'll get into a lot more detail about those when we cover the immune system later on. All right, and then the monocytes are going to be about 2 to 8% of the overall white blood cell count. These are usually going to be the largest of all of the white blood cells, so very, very large. They tend to have this kind of kidney bean or horseshoe-shaped nucleus, so not in lobes, but it's still going to be kind of curved a little bit. Again, these become macrophages once they leave the bloodstream, once they leave those blood vessels. Same type of cell, different name depending on whether it's in circulation or in tissues. And so they are going to be, again, phagocytic cells. So they're going to eat up older cells, infected cells, different types of pathogens. So they're kind of a general purpose cleaning and immune response cell in our body. They're doing a lot of different things. They can wear a lot of different hats depending on what exactly is needed at any particular given time. These are also going to help produce a lot of chemicals that will signal to the other types of white blood cells that there is an injury or infection in a certain place. So they're releasing a lot of those chemicals that are giving directions to the other cells. Very high levels of these are usually associated with viral or fungal infections, a specific bacteria called tuberculosis, certain types of leukemia, and some other chronic diseases. Lower counts are going to be indicating something's wrong with the bone marrow itself. Right? Again, all of these are going to have a pretty short lifespan, usually hours to days long, depending on what is going on in the body. If they are actively fighting a pathogen, their lifespan is going to be very, very short because they are usually going to destroy themselves in the process of destroying that pathogen. But unlike the red blood cells, these can all make more copies of themselves and continue producing, so they don't exclusively have to be made in the bone marrow. Of these lymphocytes, the B and T cells, it's really important that they can make copies of themselves. So the B lymphocytes end up being our main memory cell for different types of infections. So we want lots of copies of those floating around just in case that pathogen gets into us again. We've got those cells with that memory ready to go. So different disorders of these are usually going to be leading to lymphomas or leukemias, is going to be high numbers of a particular type of these cells. Sometimes it's only going to be a specific type, sometimes it's going to be multiple types, and so we're not going to get into a ton of detail about that, but lymphomas and leukemias are due to high numbers of these white blood cells. Lymphomas specifically are masses of malignant lymphocytes specifically, whereas leukemias, it's going to be usually these other types of cells that are mutated and producing in excessively high numbers. All right, wrapping up this video talking about platelets. These are, again, essential for forming blood clots to stop blood loss and start that repair process on damaged vessels. So these start out as a specific type of cell called a megakaryocyte. And so those megakaryocytes end up breaking off little tiny pieces of them enclosed in the cell membrane still, forming these platelets, also referred to as thrombocytes. And so they are not cells. They're not going to have any organelles or nucleus or anything. It's just that fragment of cytoplasm surrounded by the plasma membrane. These are going to be very, very tiny little pieces. The original cells are going to be very large, but the platelets themselves are small. They are going to end up, again, producing a lot of those proteins and things that are going to help seal off damaged blood vessels and end up stopping that blood loss. So very, very important. Again, very tiny, but tons and tons of these floating around in circulation. A lot of these end up being stored in the spleen that can be released really quickly if they're needed, but many of them stay circulating in the blood vessels. All right, so looking at that blood clotting, so we've got a vessel right here. If we've got a injury to that, we start losing the different types of cells and plasma out of that damage. And so these platelets and then little fibrinogen molecules will kind of join forces together and start forming this blood clot over that damaged area of the vessel. So those platelets get activated because the cells over here that have been damaged start releasing a chemical saying, help, help, we've been damaged. And so that's what's going to signal those platelets to activate and start blocking that off and forming that network of the fibrin from the fibrinogen, and start trapping some of those cells, forming the clot to stop that blood flow and that blood loss. And so we don't frequently have a lot of issues with platelets as humans, but there are some conditions that can happen. So thrombocytosis is when there are too many platelets. This can cause a lot of unwanted blood clots. That's called thrombosis. This can be fatal, and so that's not great if we have too many platelets. But if there's not enough, that is called thrombocytopenia, and that is going to lead to an inability or decreased ability to form these blood clots, which can cause excessive bleeding. Hemophilia is a genetic disorder, which is due to inadequate production of the things that make these clots happen, so that activation process of the platelets gets messed up, and so they're not forming those clots properly. So hemophilia is going to cause a lot of excessive bleeding, or a high risk of that excessive bleeding, because it is not able to clot properly. All right, we will continue in the next video talking about how these different cells are initially formed.